The glenohumeral joint. As I've mentioned, the glenohumeral joint is really the primary focus of the shoulder complex. It's the primary joint because it provides the greatest range of motion in all three planes, which really is the primary purpose of the whole upper extremity. It's to position the hand in location so that we can use it to manipulate objects in an environment, protect ourselves, and move ourselves throughout the world while manipulating the objects around us. So let's take a close look at the glenohumeral joint, including the bony anatomy, the cartilaginous and soft tissue structures, including the ligaments, and then talk a little bit about its function and its stability. So the glenohumeral joint is a ball and socket joint. The ball is formed by the humeral head, and the socket is formed by the scapula, specifically the glenoid cavity. So we can see the ball and the socket here, and I'm going to repeat this over and over, but it's inherently unstable, right? So this is the ball of the, this ball and socket. This is the socket. The socket is very shallow from a bony perspective, and therefore, you can almost think of it as trying to balance, a bowling ball on a flat surface or a very mildly concave surface, small concave surface. So it is inherently stable. So the bony anatomy does not lend itself well to making this region very stable. However, it does lend itself well to allowing for a large amount of motion. That motion in this joint occurs in three planes or in three different degrees of freedom. So we can move into flexion, extension, abduction, adduction, and internal and external rotation. We'll look at what these are here in a couple minutes. So anyway, it is a joint that is built for motion. Therefore, since the bony anatomy isn't real stable, we have to rely on other structures, and we'll talk about those. The humeral head is more than twice the size of the socket, so the ball is twice the size of the socket, which again is part of the reason why we see it to be an unstable joint from a bony perspective. There is a large capsule that, encases this joint. It's a synovial joint, so it has a joint capsule that then has synovial fluid and so on. But the joint capsule is fairly loose as well, and it needs to be to allow us to get our arm into all of these different positions around our body. So, again, that's the basic kind of introduction to this joint. The structure, again, involves the humeral head, and the humeral head forms about a third, maybe a little bit more of a sphere, and we can see that here. And it's going to roll and glide and spin upon the glenoid cavity, which is the socket, which is formed on the scapula. And as I said before, we can see the socket here formed by the scapula. And again, we can see how it's positioned in relation, their bones are positioned in relation to one another. And we can also see it from a superior view in this bottom picture. And the reason I point that out is the humeral head actually comes in at a somewhat of an angle, about a 30-degree angle. So it doesn't come straight in from the lateral aspect. It kind of comes in from an anterior lateral aspect. Often in the gym, in the athletic training room and so on, you'll see people doing exercises where they have their humerus about 30 degrees away from directly lateral when they're doing different types of exercises. Those exercises are said to be occurring in the plane of the scapula, and that's because the scapula points about 30 degrees anteriorly, or that socket points about 30 degrees anteriorly. And that's sort of that natural position where we often will do exercises in addition to sort of the cardinal planes of motion. When we consider the socket and look at it a little bit more closely, we do have some connective tissue structures that help to deepen the socket as well as hold the humeral head in place. The most important of them is called the glenoid labrum. We see labrums in a couple different joints throughout the body, notably the hip and the shoulder. And a labrum is a cartilage ring. It's basically a ring of cartilage that goes the whole way around the socket, deepening the socket. So it's a cartilage ring called the glenoid labrum that deepens the glenoid fossa, or the socket that the humeral head fits in, making it somewhat more stable. It prevents the humerus from sliding out of the fossa. So again, because it deepens it, it acts as a wall or a barrier to keep the humeral head from sliding out of the joint. The Glenoid labrum can be injured. In throwing athletes, we'll often see labral tears. In acute injuries to the shoulder complex, where there's a subluxation or a dislocation, often the glenoid labrum can be knocked off of the bone, so that a portion of it could be loose and so on. But the glenoid labrum we can see in this picture here, and again, it's a really important structure for deepening that socket. We have a couple other structures that are going to be important. The first is a kind of a structure that they call the coracoacromial arch. So if we, again, let me take away these other drawings. We have a roof that's formed above the humeral head, because the humeral head's been removed in this image. The coracoid process is here. That's that finger-like projection that points anteriorly, because again, this is anterior. So again, so that you know. And the coracoid process is here, and the acromion process is this structure here. Connecting them both is a ligament called the coracoacromial ligament that goes across here. So we have actually a big wall or archway that's formed above the humeral head called the coracoacromial arch, forms a roof over the glenohumeral joint. Does a couple of things. First off, if I was to land on my shoulder, if I was to fall, get knocked on my side and land on the top of my shoulder, it protects the glenohumeral joint from direct impact. It also prevents the humeral head from dislocating anteriorly. Again, which is important because, again, if you have your hand pointed downward, you fall on an outstretched arm, your humeral head will be pushed superiorly, and it prevents that humeral head from dislocating superiorly. So the coracoacromial arch is a structure that's formed from the coracoid process, the acromion process, and this coracoacromial ligament, and it creates that space above the humeral head. Important to note too, the humeral head would sit here. Okay, so the humeral head would be in this space. There is actually some space in between those bones. So again, there is some space between them. And we have a number of important structures that fit in this space. Particularly right in this space here is going to be where the supraspinatus muscle and tendon pass underneath the acromion and then wrap around and attach to the humeral head. So often we have, you've probably heard of a condition called impingement syndrome. If you hear someone has shoulder impingement or subacromial impingement syndrome, often what can happen is the supraspinatus, the supraspinatus tendon can get impinged or pinched in that space because it's fairly small. Also, there are rotator cuff tears that people get from falls. That usually occurs when someone lands on their arm. The humeral head is pushed superiorly, and it can pinch or actually cut or damage the supraspinatus tendon and damage the rotator cuff. So again, we'll talk more about the rotator cuff here in a slide or two. So the bony anatomy, again, not great. The labrum helps to improve the stability of this region, and the coracoacromial arch also helps to improve some of the stability. But the coracoacromial arch is only going to help us in the superior direction. We do have a glenohumeral capsule or a joint capsule, just like any synovial joint, that encases the entire joint. And it does have some thickenings that we would call ligaments. However, the glenohumeral capsule is fairly loose and is loose because it needs to allow for a pretty significant range of motion. Unfortunately, not only is it loose, it's fairly thin. So even when it does get tight, these ligaments can be damaged fairly easily. And we see this both chronically and acutely with stresses placed upon this region. So the glenohumeral capsule provides little limitation of motion, but it does have these thickenings of ligaments. Also, important to note, more than most regions are muscles that actually cross this joint. A number of them actually attach or have some fibers that attach to the glenohumeral capsule. And therefore, when these muscles contract, they not only move the bones, they can tighten the capsule, increasing stability of this joint, which is going to be a theme that we're going to see in this region. Bony anatomy, not great. Soft tissue anatomy is not great in terms of the cartilage structures, or sorry, of the ligamentous structures, but the muscular anatomy does really the majority of the work in holding this joint together during its different ranges of motion in different positions. So there are some ligaments that I want to mention because they do play a part in helping to stabilize the joint. And basically, these are thickenings of the joint capsule. So they're called glenohumeral ligaments because they are thickenings of the joint capsule. And they form kind of a Z shape on the anterior aspect of the joint capsule. They're fairly weak, so even once they do get tight, they are easily damaged. So they don't provide great support. But again, they're thickenings on the anterior aspect of the joint capsule. The coracohumeral ligament is a ligament that goes from the coracoid process again over to the humerus, also crossing in front of the joint capsule. It's not part of the joint capsule and lends some support to this region as well and helps to limit anterior dislocations. The supraspinatus tendon also crosses through this space, as I've mentioned before, through this subacromial space and wraps around here. And therefore, when it contracts, it can help hold this joint together. The ligaments tend to prevent external rotation or lateral rotation, and also because the ligaments generally are pointing in this downward direction, they help to support the limb against gravity. So when you're at rest and you don't have a lot of muscle activity in the shoulder region, these ligaments help to support the joint against gravity, especially the coracohumeral ligament. Adding to the stability of this region are the muscles. And there are a lot of muscles that cross the shoulder complex, whether they cross and move the scapula or if they move the humerus. However, there are 4 muscles in particular that are really going to be responsible for holding this joint together and dynamically stabilizing the humeral head on the glenoid or on the scapula. And that's the rotator cuff muscles. So maybe you've heard of the rotator cuff muscles before. You've probably heard the term at least. The term rotator is because all 4 of these muscles are going to do rotation of the humerus on the scapula. 3 are involved in external rotation, and 1 is involved in external or internal rotation. Cuff, they use the term cuff because the tendons all, in addition to inserting into the humerus, they're going to have some fibers that also insert into the joint capsule, thickening the capsule and allowing the capsule to be dynamically tightened and stabilizing the joint. They are uniquely positioned, very close to the joint axis of rotation, and therefore can not only, again, move the joint, but also pull the humeral head into the glenoid cavity, centering it basically in the glenoid cavity and increasing stability of this region. So let's take a closer look at the muscles that comprise the rotator cuff. So let's take a closer look at the actual muscles that comprise the rotator cuff. They include the sits muscles, which often you'll see abbreviated, again with the first letter of each name of the muscles, but they include the supraspinatus, infraspinatus, teres minor, and subscapularis. These 4 muscles really are uniquely positioned to allow for the movement of the joint, but also stability. So when you look at the supraspinatus, which is this superior muscle up here, if we look at the infraspinatus, which is the largest of these 3 muscles at least, which is here, and when we look at the last of the muscles, the teres minor, which is here, they all are positioned very close to the joint itself. You can see that they all insert down here into the humeral head. And what you don't see is that those fibers not only attach to the bone, but they have fibers that go into the joint capsule, allowing the joint capsule to be tightened. All 3 of those muscles, what they will be able to do when they contract is they're going to pull the humeral head towards the scapula into and centering it in the glenoid cavity. So these 4 muscles, because they're posterior to the joint, are going to be external rotators, but really their primary function is going to be to help to stabilize this joint when we're moving the shoulder through various ranges of motion. The fourth muscle, the subscapularis, you can't see in this picture because it's on the anterior aspect of the joint. It actually originates off the anterior aspect of the scapula, crosses the anterior aspect of the glenohumeral joint, as opposed to the other three, which are on the posterior aspect. And again, it's going to have the same line of pull, basically, although it's an internal rotator. It will pull the humeral head into the glenoid cavity. And typically what we get are force couples. A force couple is where two or more muscles contract at the same time. So typically we'll have the subscapularis, for instance, contracting at the same time as the infraspinatus. So the internal and external rotation caused by those two muscles cancel out, and our end result is just the humeral head being pulled into the socket, adding to stability of this joint. Another important muscle in helping to stabilize the glenohumeral joint is the biceps. I think a lot of us think of the biceps primarily as an elbow muscle, but it does cross the shoulder complex as well, and helps to link the function of these two joints, but also helps to add to the stability of the glenohumeral joint. So remember the biceps, bi means two, so the biceps has two heads. One head, the medial head, you can see here, inserts into the coracoid process. The long head, however, has an interesting path. It passes through the bicipital groove on the anterior aspect of the humerus. It passes actually through a tunnel because there's a ligament called the transverse humeral ligament that goes across this groove, and then the biceps goes underneath it. And then it inserts into the very superior aspect of the glenoid cavity. So at the top of the socket, it actually has fibers that also attach to the glenoid labrum. So its position allows for the humerus to, again, be pulled upward when the biceps contracts. So the biceps really helps to keep the humeral head from dislocating or subluxing in an inferior direction. Actually interesting to note is that typically we think of tendons moving on bones, but it's actually, in the case of the long head of the biceps, when the humerus moves, it's the humerus moving on the tendon because of its attachment site. So whenever we're moving our shoulder, especially into like flexion and extension, the humerus is sliding on the biceps tendon as it passes through that groove. That does often lead to some dysfunction in this region, and we can often get pain on the anterior aspect of the shoulder because of this wear and tear of the biceps tendon sliding in this tunnel, and it often getting impinged if it does get inflamed and so on. But the biceps plays a very important role at the glenohumeral joint in adding stability to this region. The glenohumeral joint, because it has so many muscles that cross it and so many different bony prominences, has a very large number of bursa. So a bursa, again, we've probably learned about when you've looked at other joints. A bursa is basically a synovial sac that sits between typically a tendon and a bone, and it keeps that tendon from rubbing on the bone. So we see a number in this region that can be important clinically. Most importantly are the subacromial bursa. The subacromial bursa sits in this space here, between the acromion process and the humeral head. It's in that same space as the supraspinatus tendon underneath the subacromial arch, or the coracoacromial arch. Therefore, it can often become impinged or inflamed when we do a lot of overhead throwing activities and so on. So again, it can become problematic. There's another important or relevant bursa called the subdeltoid bursa. It sits basically over the lateral aspect of the humeral head, and where the deltoid would rub on the humeral head during contractions. Again, decreasing the friction between the bone and the muscle as it moves. So again, we do see a lot of bursa found in this region. Typically, bursa are not palpable or that noticeable in terms of their location unless they become inflamed and irritated. So to wrap up the glenohumeral joint, I want to talk about some of the motions that are allowed at or occur at the glenohumeral joint. And while we've seen that this region, this joint is fairly unstable, Its instability is what gives us this huge range of motion. And again, this motion that occurs is in 3 planes. So the glenohumeral joint affords the whole upper extremity a very large range of motion. We can move our arm in front of us, behind us, out to the side, across our body, and so on. So let's just quickly review, if you don't know them already, what the terms are for these motions. So the first motion that I want to talk is abduction and adduction. It's motion that occurs in the frontal plane, and we can see it occurring in this picture here. So that's anatomical position would be an adducted position. Your body is at your side. And then when you move away from the body, that would be abduction, abduction. And we can abduct to almost directly over our head, so about 180 degrees of motion. The glenohumeral joint occurs for about 2/3 of that total motion. The rest of the motion comes from an upward rotation of the scapula. The next motion is flexion and extension. And flexion and extension is motion in anterior and posterior direction. It occurs in the sagittal plane. Flexion is when you move your arm in a forward direction. So again, straight up over your head, but in front of your body this time, as opposed to out to the side. And then extension is motion behind the body. We have, again, about 180 degrees of flexion in the shoulder complex, with again, roughly 2/3 of it, again, occurring from the glenohumeral joint, the other third occurring from the scapula moving on the thorax. Extension, we have far less motion. Again, depending upon the person, 45 to 50 degrees is an average. But again, that's when you move your arm straight backwards. The next motion is rotation. So this is the third plane of motion, internal and external rotation. Again, you can see it in this picture here. This individual, if we look at him from above, he's got his arm straight out in front of him, so he's still in a kind of a neutral position. When he moves his arm this direction, that's internal rotation, which often is also called medial rotation. And then you have external rotation, which is motion away from the midline, or lateral rotation. So most books are going to call it internal, external rotation, but again, you can see it both. We can also measure it here with the arm abducted, again, abducted to 90 degrees, and we can measure internal, external rotation that way as well as do exercises in this position, right? So those are the motions that occur in the cardinal planes. Another motion that's often attributed to the shoulder, however, is when we're already abducted to 90 degrees, so our arm is out to our side, parallel with the ground, and then we can move it towards the front of our body or towards the back of our body. So in this individual here, straight out would be right here. If she had her arm straight out, moving it this direction would be called horizontal abduction, and then this would be called horizontal adduction. And again, that's frequently what we do in terms of using our upper extremity. We have our arm up out to our side, or in front of us, or out to the side, and we move it forward or backward. But again, those are the terms that we're going to be using when we look at each of the individual muscles and talk about the motions that they cause at the shoulder complex. And again, these are the motions that occur at the glenohumeral joint. While these motions occur at the glenohumeral joint, we typically also have some motion occurring at the scapula, which would be the terms we learned when we went over those joints, which would be retraction, protraction, upward rotation, downward rotation, and so on. So again, we'll look at each of these terms in more detail when we look at each of the individual muscles.